Everybody, and welcome to Cancer Council Western Australia's Cancer Council Update Series for 2019. My name is Melissa Treby and I'm the Cancer Smart Manager at Cancer Council WA, and I'd like to thank you all for coming today to our presentation, The Current State of Play with Immunotherapy Treatments. Excuse me. Before the presentations begin, I'd really like to ask everyone to please make sure that you have your mobile switched off or turned to silent. Today's presentation will run for about 45 minutes, followed by 15 minutes of questions from the audience. And for some of you who come to our series regularly, you'll know how it all works. We'll be recording today's lecture and the questions at the end so that we can put it on our website for those of you for the people who couldn't make it today. But as I said, we'll have 15 minutes of questions at the end, so there's hopefully ample opportunity for some of you to ask some questions if you have them. Before we start the talk, we'd like to acknowledge the traditional custodians of the land, the Noongar Whadjuk people. We'd also like to pay respect to the elders past, present and emerging, and offer our acknowledgement and respect to other Aboriginal and Torres Strait Islander people who are present. So today we will hear from Dr. Ryan Sullivan. Dr. Sullivan is board certified in medical oncology and an attending physician in the Division of Haematology, Oncology at Massachusetts General Hospital. He attended Colby College for undergraduate studies and then matriculated to the University of Connecticut Medical School, graduating in 2001. He first trained in internal medicine at Mount Auburn Hospital in Cambridge, Massachusetts, and then at Beth Israel Deaconess Medical Centre in Haematology Oncology. He is the Associate Director of the Melanoma Program in the Massachusetts General Hospital Cancer Centre and a member of the Termea Centre for Target Therapy. Dr. Sullivan is an active clinical and translational investigator whose main interests are the development of novel molecular therapeutic and immunotherapeutic combinations for malignant melanoma, the translation of promising preclinical findings into early-stage clinical trials, and the development of predictive biomarkers for these investigational as well as standard treatment approaches. In addition, he has an active interest in improving the prediction through the development of blood-based biomarkers and the management of immune checkpoint inhibitor toxicity. So Dr. Ryan Sullivan has come a long way today, many flights I'm sure, and we're really, really delighted to have him here. So please join me in welcoming Dr. Ryan Sullivan.
Thank you very much for that kind introduction and for that kind introduction with applause. I appreciate it. Hopefully I'm worthy of it. Fortunately, I didn't fly in today, so I got a reasonable night's sleep and I'm not too jet-lagged, but fly out tonight for a very long journey back home. So I'll start by just disclosing, relevant disclosures that I serve on advisory boards and consult with a number of companies, and then have some research sponsorship from a couple of pharmaceutical companies as well. So I think it's fair to say, if anybody's been following the news, and certainly if people have unfortunately been touched by cancer, that this era of immunotherapy to treat cancer has arrived. It's arrived in our science journals. It's arrived in popular culture. And I think it's one of the most exciting things to happen to medicine in certainly the last half century or so. And more importantly, the data that has driven this revolution has led to the Nobel Prize in Medicine this past year to seminal researchers in this field. So it's receiving its right approval by both the medical community, the science community, and popular culture. So I like to start with a few truths, and the first is this fundamental truth, that every cancer that's ever been diagnosed has had to figure out a way to defend itself. I put self in quotes because obviously a tumor isn't a sentient being, but sometimes it seems that way. But it's figured out a way around the immune system. It has to. Our immune systems are built to defend ourselves from invaders from outside, but also from trouble from within. The immune system is our defense against bacteria and viruses and worms and parasites, but it also defends ourselves against cells that have gone wrong. The guiding principle of immunotherapy, particularly immunotherapy in cancer, is that an individual's cancer can be eradicated if only the immune system can be instructed to do so. And so throughout the next 35 or 40 minutes, that's the guiding principle. That's what we're trying to do to help our patients with cancer. So there's a not-so-recent proof of principle. So this gentleman on the right of that screen, his name is Thomas Cooley. He was an American surgeon and had a patient who had a very large tumor in the neck. It became infected. The patient nearly died of the infection, and while recovering from his infection, the tumor went away. And Dr. Cooley didn't believe that this was some miracle that came out of nowhere, but really believed that there was something to do with the infection, the body's response to the infection, that then interacted with the tumor and eradicated it. And he believed so much in that he began to grow the bacteria, isolate toxins from the bacteria, and give it to patients. And that was called Cooleys toxin. And you can still find it, although it didn't work particularly well. But at least it was the earliest published and then tried to be developed immune therapy for patients with cancer. Now, why did this work? Well, the idea is that the injection of the toxin triggers a whole bunch of things in the body. And in the right setting, what it triggers is factors that are released by cells, immune cells, that trigger other immune cells to get into the tumor and eradicate the tumor. And that's the concept of this miracle that this patient had and other patients that have been described, that the infection triggered an overwhelming response by the immune system, and somehow the right cells that could recognize that cancer got into the cancer and destroyed it. We have a semi-recent proof of principle. So the gentleman on the left is Steven Rosenberg. Now, this is back when he was a younger man in the early 80s. He is now in his early 80s and still working at the National Cancer Institute in the U.S. With the current shutdown, I presume he's still working in the National Cancer Institute in the U.S., but maybe not be getting paid. But in any event, his group isolated a substance that the body uses to stimulate cells called T cells. And T cells do most of the work to attack cancerous cells and cells that are infected by viruses. And what he showed, and others showed together, was that this substance, when given at high doses to patients with melanoma, didn't help everybody. But the people it helped lived for a long time. I don't like showing Kaplan-Meier curves, which are basically survival curves, to public audiences because they're a bit frightening, but this is a very old curve, and I think what I want to show, if I can, with the pointer, do so, is to show you that this curve is stable. When you see a stable curve over years, we tend to think of that as cure. And so this was the first immune therapy that tended to be considered curative. Again, most patients weren't cured, but those that had amazing responses were. And there are patients treated in the 80s and 90s and early 2000s that still come back to melanoma clinics and kidney cancer clinics across the world and certainly across the U.S. And are disease-free, living their life off of therapy. And ultimately, this is what patients with cancer would strive for. Patients generally are willing to go through anything to feel better and to get rid of their cancer. But when they're done with treatment, they'd like to be done, and they'd like to be cured. And high-dose interleukin-2 was the first drug in the modern era to offer that possibility. Again, not to most patients, but to some. Now, why does this work? I like to think of this more as that the tumor itself is primed to respond to this. Essentially, that there's a smoldering fire of immune cells trying to interact and eradicate cancer cells, but it just needs a little push. And with a little push, the tumor becomes quite inflamed, and then when the fire burns out, the cancer is gone. Now, how about stepping into the modern era. So in this century, the proof of principle is something called immune checkpoint inhibitors, and anti-PD-1 is our shining checkpoint inhibitor star. I'll show you a picture. I'll try not to get too technical. But anti-PD-1 is a type of therapy that interacts with a key binding interaction that blocks the immune system. Cancer cells are very clever about how they get around the immune system, and one way they can get around the immune system is essentially putting something on the outside of them that interacts with invading T cells and shuts those T cells down. It's actually something that our body has developed to protect itself. For example, if we were to get the flu, we want our immune system to get rid of the infected cells that have the flu in it, but we don't want those cells to then continue to destroy the tissues, for example, our lungs, that are infected with the flu. We want there to be a shutdown, and anti-PD-1 is one of these key breaks in the immune system. So this is the reason I'm standing in front of you. It has nothing to do with melanoma, although these drugs are quite effective for melanoma, but this is actually a patient with lung cancer. And when these drugs were being developed, it was expected that they would help patients with melanoma. Not everybody, but that some percentage of patients would benefit from these. Because high-dose IL-2 works for melanoma, it was thought that all the immune therapies that would be developed afterwards would work in melanoma. It was not expected to work in lung cancer. Because it worked in lung cancer, and throughout the world, lung cancer is the most common and deadliest cancer, it inspired companies that could make a lot of money to invest a lot of money into this field and to develop drugs that would hopefully make them money, but fortunately they also developed drugs that may be saving patients' lives. So this is a patient who was treated with this drug. This drug is now called nivolumab. At the time it was called MDX-006. The patient actually, after 2 months, the tumors grew a little bit and then they went away. This is the 4-month scan here. These were where the tumors were, and this patient went on to have a complete response to therapy and may be cured. We hesitate to say that any patient is individually cured, but we feel comfortable saying that patients who have durable response for a long period of time are likely cured. This patient was likely cured. So how does this work? Well, it's complicated. There's a lot of interactions that happen in the cells, and just to take you through this picture very briefly, this is a tumor cell. A T cell. This is tumor cells. These are cells that interact with a T cell, and basically the immune cells have to be able to recognize the cancer, then they have to be able to be primed to then go in and attack the cancer. And I'll walk you through that. And basically, how does the body kill cancer? So there needs to be 3 major steps. The first step is that the tumor needs to be recognized by the immune system. And there's certain ways, or so-called receptors on T cells that interact with little proteins that help educate those T cells that that's a cell they need to go and attack. But these little proteins are on all of our cells. So we don't want those T cells to attack all of our cells. That's a disease state called autoimmune diseases. There's a number of those, but some of them go by the names that you've probably heard of: rheumatoid arthritis, lupus, Crohn's disease, ulcerative colitis. These are all autoimmune diseases where our body is attacking our tissues. So there's a careful regulation because we don't want every T cell to be activated when they come in contact with the protein. So there has to be a controlled system that has gas pedals and brake pedals, and there are key brakes along the way. And then once those T cells have been activated, and they then need to get into the tumor and destroy the tumor. And when it works, it's amazing. So this is a cartoon that I have to thank one of my colleagues, Jennifer Wargo, for letting me borrow and make my own. But that's essentially what happens. It has to go in and destroy the tumor cell. Now, each of those steps along the way may be ways of actually making these types of therapies better. So if we can make immune recognition better, well, then maybe we would make immunotherapy better. And so this was from 60 Minutes several years ago. I don't know if anybody in the audience saw this. This was a polio vaccine that was being given to people with a certain type of cancer in the brain called glioblastoma. And during surgery, they would inject the polio virus into the tumor. And then what it would do is it would destroy some of the tumor cells, and it would essentially make a slurry that would then be rich with proteins that the T cells could recognize. And then once they could start to recognize it, then they would start to grow. And the idea was then they would begin to kill the cancer cells. And it works reasonably well. It's not a perfect therapy, but it does help some patients. And so when this came out, almost every patient in my clinic took an extra 10 or 15 minutes to talk about the polio virus and can I get the polio virus to treat my melanoma. And they were very disappointed to hear that not only do we not have that available, but if it was available at all, they'd have to drive from Boston to North Carolina because this was at Duke University. In any event, we got through that, so now my clinic runs a little bit more smoothly, and I'm not as late as I was for those few weeks after this. But essentially what we're looking to do is find more specific T cells. And giving a vaccine like that generates more specific T cells. There's also other ways we can do that. We can actually take tumors out and remove the T cells from the tumors. Those are as specific as you can get because they got to the tumor for a reason. We can also engineer T cells, and we can put little receptors on the surface that can better recognize cancer. We can engineer T cells that have what are called chimeric receptors, which are different than native receptors, and all of this can lead to more effective therapies. However, the kind of shining star in these types of therapies, and I don't know if anybody's heard of these because they have a cool name, they're called CAR T cells, or chimeric antigen receptor T cells. These have now become FDA approved in the States for a couple of malignancies, certain types of leukemias and lymphomas. However, they're not quite ready for prime time in melanoma. There's a lot of issues that still need to be overcome before these will be effective therapies. But if people have heard about these, I at least wanted to mention these as a type of immune therapy because they certainly are, and they may one day be used in melanoma. Another way, I mentioned the polio virus, but there's actually an FDA-approved herpes virus that's approved to treat patients with melanoma. And the way that this works is we have to have something we can feel. So the patient has to have a tumor nodule or a lymph node that's palpable. And then we stick a needle in it and inject this herpes virus. The herpes virus is engineered not to cause infection of the skin or breakouts. And what they took out, they took a part of the virus out for that, and in its place they put in a gene that actually generates a substance that attracts in immune cells. And so the way it works is, number one there, it's the virus gets into the tumor and infects the tumor cells. It then explodes the tumor cells and releases a lot of the proteins that are in those tumor cells, and then it also attracts in immune cells. And then the hope is that those immune cells are multiplying in there and are eradicating that tumor, but also have the potential to spread to other tumors and do their business there and attack and destroy tumor cells. And in fact, we commonly see if somebody has 5 tumors, you can inject 1 or 2 and all of them will go away. The key, in which we haven't seen quite yet to enough degree to feel really confident about using this as a treatment by its own, is if you inject a tumor, what we'd really like to do is inject a tumor in the leg and see a tumor in the liver or the lung go away. And that's not quite what happens with these types of therapies. So it's not a great therapy for somebody who has actively growing disease in important organs, but it's a very effective therapy for people who have local or regional disease that's bulky and causing problems and is uncomfortable, if not immediately life-threatening. So how about improving immune activation? So this is actually where the literal money is. This is where all of the pharmaceutical companies are looking at, and what they're looking to do is to target these interactions which activate immune cells. And one of the key ones is called CTLA-4. The name doesn't matter. But CTLA-4 is the target of a drug called ipilimumab, or Yervoy. This drug was FDA approved in the U.S. in 2011 and soon thereafter in Australia and the rest of the world. It was an amazing drug, not because it helped everybody. In many ways, it's a lot like high-dose IL-2. It helps maybe 20% of patients, but the 20% of patients it helps for a long time. And in fact, on the early studies with this drug, about 20% of patients have long-term survival, which was much better than the long-term survival percentage would be of metastatic melanoma 10 or 15 years ago. So it was really an exciting drug and the first of these new drugs to be approved. And finally, there's the getting the immune cells in. And perhaps more importantly, helping the immune cells that are in work more effectively. That interaction I described before, where the immune cell and the tumor cell are interacting, it's essentially acting as barbed wire. The T cells just can't quite get to the tumor cell to destroy them. And so what was designed were drugs that block that interaction, and in doing so, it allows the T cell to be lethal against the cancer and allow patients to live longer. So this is a slide that I made in December of 2017, and I'll never make it again because I can't find the part that did this, and it's just becoming more and more complicated. So I'll just leave this as a relic. But really what's impressive about this slide, other than the 3 hours or so it took for me to make it, is the fact that over time what you can see is a lot more arrows. And these are the various different cancers and the different types of therapies that have been approved for those cancers over the last decade or less than a decade. So 2011, I mentioned, was where ipilimumab was approved. Nivolumab and pembrolizumab, which go by the names of Opdivo and Keytruda, were approved in 2014 for melanoma. And then after that, there are probably now 12 different diseases where one of these 6 or 7 drugs, there's actually a 7th drug that's not on there that was approved this year or this past year. It's amazing how rapidly this has taken off. And now we have FDA approvals for melanoma, non-small cell lung cancer, kidney cancer, bladder cancer, Hodgkin's lymphoma, head and neck cancer, Merkel cell carcinoma, squamous cell carcinoma of the skin, a general type of cancer type called microsatellite unstable cancers, stomach cancer, liver cancer, esophageal cancer, and on and on. It is not a misstatement to say that these are the most exciting drugs to hit the market in the past probably 50 years. And again, not so exciting because they help everybody, but when they help patients, they can help them for a long, long time. And so the advanced melanoma treatment landscape with respect to immunotherapy includes high-dose IL-2 with probably about a 10% cure rate. Ipilimumab with about a 20% cure rate, and then these newer drugs, pembrolizumab and nivolumab, and the combination of a couple, where we're probably seeing 30 to 40% cure rates. Not good enough, but amazing from where we've come to see 5-year survivals of 2 to 5%, now being 5-year survivals of approaching 50%. It's just a different era and a really exciting one. So the summary on immunotherapy with regards to melanoma up to this point of the talk, the era has arrived, response rates, improved survival seen in a number of cancers, and the cure rate's improving, but there's more work to be done. So I've just talked a lot about the upside to these therapies. Is there any downside? So one of my favorite bands is Talking Heads, and they had this song called Burning Down the House in the early 80s, and it starts by saying, watch out, you might get what you're after. The immune system generates, I showed that picture of the flame and the gasoline before. It generates inflammation, and that inflammation is a bit like kind of a smoldering fire. And fire is great. We wouldn't be where we are as a species without fire. But it also can be really bad. And so when the immune system gets going, it can be just like a wildfire that gets out of control. And so the types of side effects that we see are not the classic side effects of the chemotherapies from the bygone era where people develop nausea and low blood counts and feel terrible, and you just have to wait long enough and then those side effects will go away. Essentially, chemotherapy is akin to being poisoned, but not lethally, and so people recover. With these therapies, it's not just about supporting people through the side effects, but actually directly treating the inflammation that's causing the side effects. So I think it's fair to say that checkpoint inhibitors can be dangerous. They certainly don't cause side effects in everybody or severe side effects in everybody, but they can. So this is a Consumer Reports. I wasn't on the Consumer Reports, but one of my patients made this for me. It says, "What you don't know about your doctor could hurt you. I promise you I never hurt that man. I don't know why he brought it to my clinic, but he does like to give me a hard time, so maybe that was it." But I at least like to show this as a way of proving the point, or at least making the point that what we do can sometimes hurt patients. And there's a lot of different types of side effects we can see. We can see gut side effects, so inflammation of the stomach or the intestines or the colon are common. Inflammation of endocrine glands like the pituitary gland, which sits at the base of the brain, or the thyroid gland that sits in the neck. The lungs can get inflamed. The liver can get inflamed. Joints can get inflamed. Hearts can get inflamed. Just about anything in the body can get inflamed. And there's really, generally, I like to tell my patients, about 4 different categories of side effects. There are the side effects that are annoying, and we can just manage them while patients are going through therapy, and when we stop the therapy, they'll go away. We don't worry so much about those side effects as creating big problems, but we certainly appreciate that they may impair quality of life, and that managing them makes a lot of sense. There are the side effects that can be permanent, but will allow us to keep treating. So, for example, if somebody is getting therapy and their thyroid gland becomes inflamed and stops working, we can give back what the thyroid gland is making. And in a pill, you wouldn't want to have to take a pill for the rest of your life if you didn't have to, but just about everybody in this room might trade long-term survival for having to take a pill every day while you're living long-term. So that's another type of side effect. Permanent, but relatively minor in terms of impact on life. Then there are the severe side effects that are reversible, but may in fact lead us to stop the therapy because they're severe enough. We have to give something actively to suppress the immune system, and then we really think hard about whether we're going to continue with that line of therapy. And then the 4th category are the life-threatening side effects, which occasionally occur and occasionally are not just life-threatening but lethal. They're rare, and depending on the treatment, they happen between 0.5% and 1.5% of our patients, even with being quite vigilant. But they're rare, but it's important for us to notice them. 1, to manage patients and prevent that if we can, but 2, make sure that patients understand that one of the possible outcomes is that they could die from the therapy. Toxicity is a growing problem. So this is data from our hospital. It's dated a few years back, but it just sort of shows the slow but now exponential rise in the number of hospitalizations for these types of toxicities. We've actually gone to having a separate part of the hospital and a separate group of doctors taking care of these patients when they get hospitalized because it is so complicated to manage these patients. And it's a trend that's beginning to start. A lot of hospitals are now starting these types of services in their institutions because it does provide a great way of recruiting in the various subspecialists that are required to manage these patients. So just to summarize this part of the talk, anything in the body can get inflamed with these drugs. Early recognition and treatment is critical. If we know about a side effect early, we probably can manage it. If we don't know about it, we certainly can't manage it. And we involve a network of subspecialists. Our current service has about 50 members who attend to that, and from about 20 different specialties. It's really an amazing group, but you need an amazing group often to manage these patients. You don't need all of these people for every patient who gets a side effect, but you need a couple of them. And it's great to have people with this type of expertise. The therapy, interesting, I didn't show any data, but this therapy can be given to high-risk populations. So the side effects are essentially autoimmune in nature, but we can deliver this type of therapy to patients who have autoimmune conditions. We just have to do it carefully. We tend to have specialists involved from the beginning, and we often will give treatments to modify what we think are going to be amplifying symptoms from their underlying autoimmune disease. Interestingly, advanced age is not associated with higher toxicity. With chemotherapy, it is. Giving a chemotherapy regimen to a 20-year-old versus a 90-year-old is vastly different. And these drugs can be given at full dose to older patients, and they have the same chance or maybe even slightly better chance of benefiting. The best example of that is one of our ex-presidents of the U.S., Jimmy Carter, who had widespread metastatic melanoma to his brain, to his liver, to his bone, and received pembrolizumab, which at the time I was telling my patients was called Jimmy Carterimab. And he had a complete response to therapy and is now 93 or 94 years old, continuing to do the great work that he's done since he stopped being president. Is a wonderful, shining example of not just somebody who's a popular figure, who's done well with this type of therapy, but an older popular figure that can sort of really show us that these therapies can be safely delivered to older patients. The probably two take-home points are this. One, immunotherapy is a highly effective strategy to treat melanoma, and in particular, these newer drugs that we lump into this category called immune checkpoint inhibitors. And the second point is that immunotherapy can be dangerous and has a very different side effect profile than other types of cancer therapy. And so if either you or somebody that you know is on one of these types of therapies, it's critical that there's ongoing discussion with the treating physician about any new symptoms that come about. In the last 10 minutes or so, what I'd like to do is just kind of describe where we think we're going from here. The first thing we're doing in melanoma, and this is already happening, is we're treating patients earlier in the disease course. So the slides that I showed before about immune therapy, that was for patients who have advanced disease. It can't be removed by surgery, and it's widely metastatic. That's a different scenario. That's a scenario where if you don't treat patients, they will die of their disease. The other scenario is people who have been diagnosed with melanoma. They had a spot on their skin. It was removed. It may have spread to a lymph node, and then they've had surgery to cure them. But we know, based on certain characteristics of the tumor or the number of lymph nodes that are involved, that some of those patients, often many of those patients, will recur down the road. And if they recur, at least in an era when we didn't have these types of therapies, they would have died of their disease. And so moving therapy to an earlier stage, after surgery, for curative intent, is happening and has happened with these therapies on clinical trials, and now some of these drugs are approved by the FDA. It's a slightly different situation, though, because we are treating, say the risk of recurrence is 50%, we are intentionally treating 50% of people who don't need the therapy. And so it gets a little bit trickier in terms of side effects, particularly lethal or permanent side effects, to be treating people who don't need to be treated. And one of the things that we and many other groups are trying to do is figure out who are those people that need the treatment and who are the people that don't need the treatment. We're not quite there yet, so we just essentially stage patients, which is a way of predicting prognosis, and then based on the stage, we will offer therapy or have a discussion and then potentially offer and treat patients based on the discussion. So this is now happening. There was some really exciting data presented a year and a half ago on nivolumab, and this combination is not immune therapy called dabrafenib-trametinib, and these two treatments are approved by the US FDA and are up for approval in Australia. And then pembrolizumab, again, another PD-1 inhibitor, had a very good clinical data, and that's now up for approval as well across the globe in this setting. Stage 3, which means removed disease that is spread to lymph nodes. Where else do we go from here? Well, as I was just mentioning, it would be really nice if we could identify who will and who will not benefit from therapy. It's slightly different than who needs therapy, but either in stage 4 disease or even stage 3 disease. If we could identify which patients need therapy, we have our whole group of patients here. If we could just do a test and say, these are the patients that are going to do the best, let's offer the therapy to them. And these patients we've predicted aren't going to do particularly well with that, let's do something different for them. Right now, that might be a clinical trial, but ultimately, over time, what we'd love to be able to do is have a test that stratifies patients, treat with this least toxic, most effective therapy for as many patients as possible, and then treat with more complicated, potentially more toxic therapies for the patients that we predict won't benefit from the simpler therapy. Another way, an important next step, is to develop better therapies. It's not good enough to cure 40% of melanoma patients right now. We need to be closer to 100% of patients. And there is a lot that has been learned about the immune system and the certain targets that may be vulnerabilities in tumor or potential strengths for the immune system that we might be able to augment either in combination with the drugs that are currently approved or just given by themselves. And a ton of work is being done here, and there are currently over 1,000 or 2,000 ongoing clinical trials across the globe looking at various next-generation combination therapies for patients, not just with melanoma, but with all cancers. And finally, we need to improve diagnoses and management of toxicity. As we begin to use new combinations, we're going to find new side effects, or at least different rates of side effects. And it's just crucial that we can identify these and treat them, and ideally treat them in a way that doesn't affect the treatment of the cancer. The potential downside of treating a toxicity is the side effect is immune-related side effect. We are giving immune therapy to try and have the same sort of effect, but having that happen in the cancer. And if we give very generalized immune suppression, that may also suppress the effectiveness of the anti-cancer therapy. However, we do what we have to do. If a patient has a life-threatening side effect, we have to give them the immune suppression. But we'd really love to know that those patients were either at risk, so you could imagine a scenario where we had a test to do, and we could say, you're at risk for this immune toxicity, we're going to give this treatment to help prevent that toxicity from happening, and we've proven that it doesn't affect the therapeutic effect against the cancer. And that's the type of things that are going to be, I think, quite commonly done in the next 5 or 10 years. They're not being done at all right now. But we're getting smarter about figuring out who's going to develop toxicity, and then we will get smarter about figuring out what we can do to prevent or at least lessen that toxicity without affecting the anti-cancer effect. With that, I'd like to thank you for your attention, and I ended a little bit early so we can have a little extra time for questions. Thank you.
Oops. Okay, thank you very much for that, Ryan. Before I ask for any questions, I just wanted to let you know Sandra will be using a roving microphone, and because we are recording, please wait till you get the microphone before you ask your questions so that we can share the questions with people who weren't able to attend today. So, with that in mind, has anybody got a question for Dr. Sullivan, please? Just raise your hand. Lots of people. So, Sandra, just...
Doctor, thank you very much for all your great work. It's appreciated by all of us here this morning, I'm sure of that. But a couple of questions. One, the USA obviously is a leader in the treatment of melanoma and the various strategies used. Is Western Australia, to your knowledge, equal to the USA in terms of the treatment available to patients?
So it's my understanding that most of the therapies are approved, that are approved in the U.S. I think the therapies that are up for approval are the therapies after surgery, which have been approved in the U.S. So patients with stage 3 disease, which again would be disease that was removed, but it spread to a regional lymph node. We have therapy available that we don't have to go through a trial and will be covered by our insurance programs, various insurance programs. So I think in many ways Western Australia is more advanced than the U.S. because actually everybody has health care, which is not a guarantee in the United States. And so I think what the challenge is when you have a universal healthcare system, there's obviously it's less driven by the companies wanting to get their drug on the market and the doctors and the patients wanting it on the market so we can pay for it, and more for does this drug meet the set criteria to not just be approved but to be covered by the government, so I think that's a little bit that can sometimes slow down not necessarily the approvals, but the widespread availability. It's my understanding that many of these drugs, if they're not approved, are available in what are called expanded access protocols. So these are scenarios where a company realizes that a country doesn't have this available, but that they're working to have this made available. And so they'll allow access through oncologists that have had experience running clinical trials with these drugs and make it available for that population. So I know that's happening with the drugs in the stage 3 setting, and I think for the stage 4 setting, it's already in place. You don't need those situations because all those drugs are already approved.
Doctor, the second question, very briefly. You mentioned there's something like 2,000 trials ongoing at the moment around the world. Are they coordinated in any way so that trials are not being replicated, but in actual fact going into new territory and possibly using resources that are not just being, should we say, wasted? No. So there's a lot of overlap in those studies. Company 1 doesn't care what Company 2 is doing except for the fact that they want to be ahead of Company 2. And so there's an awful lot of overlap in populations that are being targeted by these studies. And in the sort of capitalist way that drugs are developed, I'm not sure how you get around that. The gentleman down here? She's making her way down.
Hello, I was just wondering if you had done any extra work on Merkel cell carcinoma.
So our group has a few specialists that are interested in studying Merkel cell carcinoma. I personally see a few cases a year, although now what we tend to do is those cases go to the people who are hired with that specific interest. These drugs work for Merkel cell, and 2 of these drugs are actually FDA approved. One of the drugs I mentioned, which is pembrolizumab, and another drug called durvalumab, which is a PD-L1 blocker. So PD-1 is what's on the T cell, PD-L1 is what's on the immune or the tumor cell. So they both target, blocking that interaction is where the magic is. So you can block it either way. So those 2 drugs are approved for Merkel cell and work about 45 to 55% of the time. But all the challenges that we're having in melanoma are also with Merkel cell with these drugs. The toxicity of these drugs is applicable to every population of patients that we're treating. And so understanding that will help everybody who's treating patients with these drugs and everybody who's receiving these types of drugs. But so I know that there also are a lot of interest in kind of figuring out what to do when these drugs don't work in Merkel cell. Sure.
Exciting times with cancer. Just out of interest, if for immune suppressant drugs, if you've got drug A that just beat a melanoma, and let's say the melanoma comes back, 2-3 years' time, 5 years' time, will you go to that same drug, or is there resistance, and you go to another immune drugs?
Yeah, it's a great question. So for those there's the idea of resistance to therapy is a complicated discussion. It's possible that resistance could be that you just treated for a period of time, you stopped treatment because you felt it was okay to stop treating. There was no evidence of disease growth, and you figured you want to give a patient a break. And then sometime in the future, disease comes back. We treat again with the same drug that got that patient into remission, and very often it works again. I have one patient who just about every year has a recurrence. And I treat her for 3 months with treatment. She develops inflammation in her lungs, usually only on a scan, not symptomatic. I stop the therapy because her disease has gone away, and I expect that a year later we're going to do the same dance again. We've done that twice. Her last recurrence could be removed. And so there's definitely situations where we can treat, there's a response, we stop therapy, and then we come back and treat with the same drug down the road. There are other situations where that won't work. Anybody who's on a drug and develops tumors growing again, or they never stop growing, we presume that that's truly resistant to that drug and we need something different. Sometimes we add to it, and sometimes we switch. So it really is context dependent, but in theory, if somebody's been off the drug for 6 or 12 months or longer, and then they have a recurrence, we often will go back to that drug because, one, we knew it worked once upon a time, and secondly, we actually know how the patient tolerated it. Obviously, the patient tolerated it terribly, we might think about something differently, but it's more of a known, and the more things we can kind of be sure of, the better, for sure.
Thank you for your presentation, Doctor. Can you tell me whether or not this therapy is effective for the treatment of other cancers such as advanced prostate cancer or mesothelioma or those types of cancers, and if there are any trials to that effect?
So for prostate cancer, it's been a little bit tougher. So there's a small subset of patients that these drugs might work for prostate cancer, but by and large, they have been wholly ineffective in prostate cancer. There is an immune therapy for prostate cancer. It's called Provenge, which is a cell product that's you take the tumor out, you interact the tumor with the patient's a cell called a dendritic cell, and then you give the dendritic cells back. And that therapy actually doesn't lead to responses, but the PSA, which is the serum marker that we follow in prostate cancer, goes down, and actually patients seem to live a little bit longer. You had to be the right patient, so you couldn't have had disease that's growing very rapidly, that those patients wouldn't benefit from that. So there is an immune therapy approved for prostate cancer, but because it's not immediately effective, because it doesn't tend to shrink tumors down, and because there's so many other therapies approved for prostate cancer, it's not often given to patients. These types of drugs have not been that effective. Believe me, people are looking into this and trying to figure out why that is, and then try and use different combinations so that they can treat patients with that disease, because it's such a common disease, and it would be amazing to be able to offer these types of approaches to those patients.
And the other type of cancer, mesothelioma?
So mesothelioma, which is a cancer of the lining cells of either, not for you, but for everybody else, the lining cells of either the chest wall or the abdominal wall, is a pretty nasty cancer. It tends to be associated with asbestos exposure. There are some patients who have responded to these therapies, but it's rare, maybe about 10% of patients. We've been part of a clinical trial looking at nivolumab plus a different therapy that's not approved. So it's an experimental study. We saw a few responses in mesothelioma with that combination, and then are now finishing treating a few dozen patients to see what the disease control rate is in that population. That data has been presented in part, and the response rate is probably between 10 and 20%. But if that does seem to hold up, then that's a possible path forward. It's not 50 or 60% response rate, unfortunately, but it's a tough disease, and if we can even have, a double-digit or 20% response rate, that would probably be enough to justify using that type of therapy and approach. Sure.
Thank you for the presentation and information. I'm just wondering if one with lung cancer is on the nivolumab, and if it was found along the track that it wasn't holding the disease back, are the other products that you've mentioned other possibilities that you could be treated with, like in the 2018 pembrolizumab, or whatever it is.
Jimmy Carter mab? Yeah, pembrolizumab, yeah.
Or the other combination treatment. Are they other options that, in other words, there's other hope?
I mean, it's a very good question. We don't tend to think that if you're on one drug like nivolumab and you go on another drug very similar like pembrolizumab that you're going to gain anything. We don't know if you switch from blocking one side of the interaction to the other. So in lung cancer, that would be giving nivolumab and going to atezolizumab or durvalumab, whether that would make a difference. There are also data with chemotherapy plus pembrolizumab, or chemotherapy plus atezolizumab plus even another drug. So there's a lot of interest in answering that exact question. And there's a lot of interest in learning how best to treat patients after nivolumab or pembrolizumab or one of these mAbs stop working. So in general, the answer is maybe. And it's an intense area of investigation. I don't treat a lot of lung cancer patients, so I am not as facile with what I would recommend in a scenario like that. I'd have to defer to my colleagues that treat lung cancer. But as a general rule, we wouldn't use the same class of medicine by itself, but we might use the same class of medicine with something else. Yeah.
Thank you for your presentation. Correct me if I'm wrong, but it seems to me that pancreatic cancer is on the increase. It is a deadly cancer. I just want to know, are we looking at the cause of this, and are we any further in giving some life to the people who develop pancreatic cancer?
Pancreatic cancer, sure. So, pancreatic cancer is a terrible disease, as you mentioned. It's terrible for a number of reasons. One, it's hard to diagnose early. And secondly, it often is in a place that's hard to take out. And third, it often spreads to places that you need, like the liver. With respect to these types of drugs, the other thing that's a little tricky is that there tends to be a lot of what looks like scar under the microscope in pancreatic cancers. And one of the thoughts is because of that, it might be harder for the immune system to kind of traverse that scar and get to the cancer cells and do what they're trying to do. In fact, that might be the reason the scar is there. It's protecting the pancreatic cancer cells. We may have things to do to try and reverse that. Understanding why the scar-like features are there is beginning to bring to the surface a few targets that we might block in combination with these immune therapies to try and make it better. In addition, we're beginning to also think of alternative ways of treating these patients. So one of my colleagues at Mass General is doing a couple of clinical trials where he's looking at combining ipilimumab and nivolumab, which are two of the drugs we talked about, and then radiating with very high intensity radiation a tumor in the liver, and then seeing how patients do. It's been remarkable on a number of levels, this study. So far, he's seen great responses in some patients, but he's also seen great toxicity in patients. And so he actually truly believes that he's beginning to lift some of the tolerance that the immune system has towards the pancreatic cancer. So when something's intolerant of it, it does something about it and beginning to kill it. But he's also lifting some of the tolerance on important organs like the liver. But the fact that we're learning about this, to me, means that there is a path forward. Now, that path forward may not be next month, it may not be next year, but it probably won't be next century. It'll be in the relative near future where we're developing better approaches that are rational, that are based on some understanding of exactly what you say, why is this so bad, and then beginning to do studies to prove that our approach is the right approach.
The complicated interactions between cells during treatment, has medical science actually identified those, or is that a developing science?
I'm sorry, could you repeat that one more time?
The interactions between the immunotherapy chemicals and the cells, that interaction, as you explained, is very complicated.
Yes.
Has medical science at this stage actually identified those complications, or is that an ongoing developing science?
Got it. So, I mean, the picture is complicated. Sometimes simpler pictures are just underrepresenting how complicated things are. That is a cartoon, if you will, of where we, kind of what we know right now. What's clear is it's not all about the T cell. There are probably other types of cells that matter. There are probably specific types of T cells that matter more than other types of T cells, and that may help us to begin to develop more predictive tests to figure out which patients are going to do the best and which patients we may need to do something more therapies together or trials. I think the complicated part is like it's complicated with everything. We'd love to be able to identify which are the right patients, and it's not immediately obvious which patients are going to do well, which patients aren't, but we're getting better and smarter at that. It's complicated because not every tumor is receptive to the cells, and so trying to figure out why a tumor is not receptive to immune cells coming in and trying to understand that. And we're beginning to. There are a number of discoveries being made that are helping us to better understand this process. And in doing so, we're beginning to think about how to target that and make it better. And then it's complicated because resistance happens. Sometimes the resistance actually is already there because the tumor got there to begin with, and it developed resistance against the immune system. And sometimes that's cross-resistant against these drugs. And sometimes, and then it's complicated because it's not just about what's happening in the tumor, but it's what's happening with the immune system across the whole body. But we probably are smart enough as a collective to be able to figure all this out. And in 50 years, we'll think it's simple. But for now, it's complicated.
It's me. Following on from pretty much what you just said in terms of our children and hereditary nature of melanoma, perhaps, and then perhaps the hereditary nature of toxicity to immunotherapies. Is that part of the studies that you're aware of, or?
Absolutely. So with regards to benefit with these drugs or toxicity with these drugs, that can be immediately. It's immediately obvious to look. It's easier said than done, but it makes a lot of sense to say there must be some. The immune system is inherited. Our immune systems, we get half of it from our mom and half of it from our dad, and so our immune systems are, and we can figure out how to type that and understand how those interactions matter, and we know that immune systems. Certain inherited parts of the immune system can be a predictor of toxicity, or not toxicity, but diseases, inflammatory diseases. And so the challenge is there are so many different types of side effects with these drugs that you need to study thousands of patients who are getting these drugs to have an understanding about toxicity. Additionally, you probably need to study thousands of patients with lung cancer, thousands of patients with melanoma, thousands of patients with whatever cancer, because the toxicity profile is slightly different depending on what the patient underlying cancer is. So if a patient has lung cancer, often those patients have damaged lungs because lung cancer is obviously associated with cigarette smoking. And so inflammation of the lung is a little bit more common in lung cancer patients than it is in melanoma patients when we use these drugs. Inflammation of the skin, particularly a condition called vitiligo where you lose pigment, is quite common in melanoma. And so that, it's just trying to understand the type of toxicity and what inherited components that we've inherited by our immune system can tell us about that. We're learning, but it's a slow process because we need to treat a lot of people. In terms of inherited susceptibility for melanoma, there's a lot known about specific syndromes of a gene that's mutated and carried down by generations. There are a number of those genes that have been identified, not a number, but a few that have been identified. It's not very common. Most melanomas are sporadic, meaning they're not inherited. But there are some known syndromes. What we don't know is the more complex nature of inherited susceptibility because the phototype of the skin is low, or people with light eyes and light hair and light skin, that's inherited. Those are inherited characteristics that lead to susceptibility for melanoma. But if you live in Antarctica, actually that's a pretty bright place, but if you live in a box, you're probably not going to develop melanoma. So it also then goes to environmental exposures as well. So it's anytime we begin to try and tease out a multi-gene process with susceptibility to a disease, it just takes a lot of effort and a lot of patience to be able to follow that. But it's an important question to be answered.
Okay, you're very tall, Dr.
Sullivan.
So I think we'll have to finish it up there. Dr. Sullivan's been incredibly generous with his time, answering lots and lots of questions. So, and also taking time out of his really busy schedule. He's, as you can imagine, got a lot of professional engagements while he's here in Perth. So could I ask you all, please, to join me one more time thanking Dr. Sullivan for joining us.